I'm really excited today to have Jerry Noyce, who is the president of the HERO organization. Jerry became president and CEO of HERO in April 2010 after a national search for a successor to the retiring Bill Whitmer. Prior to joining HERO, Jerry was with Health Fitness Corporation, or he led Health Fitness Corporation, to becoming a premier provider of health and fitness services in the healthcare industry. Under his guidance, I believe you acquired Health and Fitness division of Johnson & Johnson and also HealthCalc. Jerry's had a lot of great experience, and today he's going to talk about a project that they've recently completed, and the topic of today's webinar is building consensus on the appropriate use of health outcomes-based incentives in a wellness program. So, Jerry, are you ready to start talking?
I am, Michaela. Thanks very much for inviting me to meet with the folks today, and thanks everyone for attending this webinar. This is actually the first webinar that we're doing on this topic. As some of you may know, we released this guidance document a couple weeks ago, or the Journal of Occupational Environmental Medicine actually released it, but it's been a work in progress since February of this year, and we're really excited about the fact that it's finally come to fruition, and pleased that we have an opportunity to share it with a broad range of employers and providers of services. And so, again, thanks a lot for being here. Michaela mentioned we'll have questions at the end. Because it's my first spin through this, I really appreciate any feedback you can give me about the presentation, which will help us as we continue to meet with different groups and share the guidance that we've created. First of all, a little bit about HERO for those of you that might not know who HERO is. The Health Enhancement Research Organization. We're a nonprofit 501c3, so we're not a lobbying organization. And we were founded in 1996 actually to do research, and I know many of you are familiar with the original HERO research studies that were foundational in terms of linking changes in health risks, modifiable health risks, to financial impact in terms of healthcare costs for employers. So that was how the organization started. Our vision has changed through the years, and this is our vision as created by our board of directors just a month or so ago, and our vision today is to promote a culture of health. So we'll talk a little about a culture of health in this presentation today, and performance, and through employer leadership. And we think that this is kind of an important statement because we talk about the importance of creating a culture of health, and I think all of us would agree that that's a very critical component to improving health of the employee population or of any population that we might be working with. And performance now enters into our discussion because we're seeing so many more organizations, employer organizations, connecting with this concept of improving productivity through optimizing performance of the workforce. And there's a lot of good research that's going on in this field. We actually at HERO have a research study that will be coming out later, beginning of August, that talks about the connectivity between presenteeism in a workforce population of about 20,000 workers and their health status and their health behaviors. And so that will be an interesting piece to add to the literature and research that's going on in this area. And then we strongly believe that employers across America are really helping to drive this whole discussion around improving health. And it's not only today about trying to have a wellness program in your organization to affect healthcare costs, to try to control healthcare costs, but it's also important for you to have that for the purpose of improving organizational performance. And I think that's a much broader view of the world, and we believe that employers are really at the forefront of leading this charge. HERO's got four major areas that we work in. First of all, I'll start at the bottom, research, which I mentioned to you, and we are continue to be active there. We have a HERO Forum, which is our conference every year, and that this year will be October 2nd to 4th in Minneapolis, and we hope some of you will attend. We'd love to have you there. One of the special features of that event is going to be the Coop Reunion Dinner, which all attendees will be invited to attend on the evening of October 2nd, which will be part of your registration. We've invited all past Coop Award winners dating all the way back to 1991 when Hillary Clinton presented the first group of awards, and we've got many of the organizations that have won Coop Awards in the past that will be attending, and we really want to make it a celebration of worksite wellness programs over the last 30 years, so hope you'll attend that. We have developed, as many of you know, the HERO Employee Health Management Best Practice Scorecard in collaboration with Mercer. That's an online tool. Just yesterday we had a conference, and our latest count, numbers of organizations that have submitted their information is over 750 now. So this database of best practices continues to grow, and we'll continue to be able to look to the data to be able, even though it's on a self-reported basis, but we can look to the data and the experience of these organizations that report to help identify linkages between practice and outcomes. And frankly, I think Michael and I, when we first talked about our doing this webinar, had thought that it might be around the scorecard. Hope to do that in a future webinar with you. But because of the relevance of the guidance document that was released and the recentness of that release, we thought this would be an appropriate topic for today. And finally, our think tank is our driving force of HERO. That's an 80-plus member company organization, represents employers, represents universities who are interested in their own programs and also in research that we do, represents consultants in the field of benefits consulting, and represents providers of services and health plans and health systems. And that group of think tank members are the ones who are responsible for the scorecard, for the forum, and help us with our research. So that's enough about us. Excuse me, I just jumped one. Let's just start to talk about what we know today and give a little background as we get into talking about the guidance. First of all, as we all know, that properly designed wellness programs really can have an impact. And that's through a lot of research that's been done over the years. We know it improves employee health. We know that there's a financial return somewhere between $2 and $3 and $4 for every dollar invested. We understand through experience of employers and through research that we can lower healthcare costs and other costs associated with chronic disease and disability by reducing health risks. And we also realize, as we talked about, that we can have an impact on absenteeism and presenteeism and improve productivity. What else do we know? Well, we know that healthcare costs are escalating and that they're at an unsustainable rate. And that's not new news to any of us. And we know that rising health insurance premiums are forcing employers and especially small businesses to drop health insurance coverage for their employees, or the other part of that would be to increase the out-of-pocket costs for the employees. And since '94, as it mentions, average costs paid by the employees have really risen. And I don't know if you know this or not, but nearly 8 times faster than the average U.S. household income. And now 36% of Americans are now forced to limit the amount of money they put toward retirement because of rising health care costs. So that's a view of the landscape. Also, healthcare spending has risen significantly between 2009 and 2010, our most recent numbers, and that total healthcare expenditures, as you know, is over $2 trillion, which is about $8,500 per person, and it's about almost 18% of the nation's gross domestic product. So this is completely unsustainable. What do we know about prevention? Well, we know that there are 4 modifiable health risk factors that are responsible for most of the chronic disease in the U.S. And as those are listed, it's tobacco use, nutrition, lack of physical activity, and excessive alcohol consumption. And that cardiovascular disease can start early in life and is affected by these risk factors. So people that reach middle age with fewer risk factors have a lower lifetime risk for cardiovascular disease mortality, and have an increased survival and improved quality of life. And Dr. Fries at Stanford and others have done a lot of work in that area to talk about the compaction of morbidity. What about health care reform? Well, the Affordable Care Act really, what it did at its basis as it related to employer wellness programs is really codified the existing statute that existed in HIPAA that allows employers to, for them to be able to charge their employees a differential in premium based on meeting certain health status factors. And this is important. That is for wellness programs that are tied to the employer-sponsored offered health insurance program. And these factors could include things like body mass index, tobacco cessation, cholesterol, blood pressure. Those are the four most common pieces. In fact, what we found out is that most of the companies that have gone to really doing this, those are the four most important measures that they've used. The other thing that the original statute allowed for, and that is in this, that's addressed in the Affordable Care Act, the statute allowed for a differential increase between up to 20% of the combined premium for both the employer and the employee coverage. So it is the total cost, or the total premium cost, not just the employee portion or just the employer portion, but it's the combined portion, and that if the program, if it includes family members, that it could be 20% of the family cost. Well, as you know, the Affordable Care Act said that starting in 2014, this limit can be raised to 30%, or will be, and that it allows HHS the opportunity to increase the limit to 50% over time if they deem this is appropriate. Now, it's interesting. I hosted a panel discussion about a couple months ago at the American Journal Health Promotion Conference on this area of discussing financial incentives, and Dr. Kevin Volk from the University of Pennsylvania, who's done a lot of research in the area of the impact of incentives on improving health, mentioned something that I thought was very interesting. And he says, you know, we as researchers for many years have done great research and found that through our research effectiveness of different things, and then have, once we have found these improvements, have then gone to Congress and tried to have legislation passed that would address these improvements that we've been able to research. Here's an example of a situation where there is not a lot of research that frankly has been done in this area at all. There's a lot of research that needs to be done yet, but yet the legislation is in place. Well, if you take a look at what this means in terms of dollars, here's a slide that shows you what the impact would be on an individual and a family plan based on 20% premium up to, or incentive, up to almost $1,100 for an individual per year and over $3,100 for a family. And what it would look like, again, starting in 2014, that goes up to $1,600 or $4,600 and could rise above that. And one of the questions obviously is out there is what is the appropriate amount that really should be, if an organization gets involved in this kind of an approach and incentives, what is the appropriate amount that really should be offered? And this gives you a wide range of possibilities. Well, one thing we also know is that employers are moving in this direction because we understand that about according to a recent survey, about 35% of the companies have reported using rewards or penalties based on smoking or tobacco use in 2012. Another 17% plan to add these incentives in 2013. And so we see that, according to Towers Watson, that 62% of these employers plan on switching from their incentive program from participation to incentives for improvement in health metrics. So this is definitely a trend that is happening. Employers are taking advantage of this opportunity through legislation to more directly tie their incentives to achieving health outcomes versus participation. And employers are innovating in this way based on being able to make an impact on their health care costs, as we know. But there's a number of concerns that have been voiced, and these concerns were voiced very strongly by some of the groups who have worked together in this collaboration, specifically American Cancer and American Cancer Network, American Diabetes, and American Heart Association, that there's some concerns about there was no clear definition in the legislation around what is a health status factor. The regulations do not really, the regulations describe that a program that would be allowed allowed to be able to offer this differential should include a reasonably designed wellness program or offer alternative standards for those who cannot meet the program metrics because of health-related conditions, but does not describe what a reasonably designed wellness program is. And as we've said, there's limited evidence that these financial incentives really will increase in terms will have an impact on increasing one's long-term health. Another concern that has been voiced is that these premium variations, whether they be offered as an incentive, a reduction in premium cost to the employee, or as a penalty, an increase in premium cost to the employee, they may penalize people with pre-existing conditions and those that have a genetic predisposition towards disease. What we do know is that evidence does show that individuals will delay needed health care because of the cost for them to be able to go in and have checkups, normal checkups, and see the doctor. So we know that that is true. We've seen that in research. And we know that high deductible benefit designs requiring significant cost sharing could create barriers to preventive care and disease management. So these were some of the concerns coming in as the legislation was initially announced and voiced by the consumer advocacy groups. On the other hand, there were other points as well, and one of the points obviously is that we know that today that businesses are spending about or covering about 76% of the cost of the total health care cost for the employees. And when you figure that there's about 150 million people that are being covered by health care today at the cost of about $8,500 per employee, that's a significant investment in health that employers are making. And there's also concern that employers need to have the ability to do some innovation as they try to control medical costs and improve the health of their employees, which is their primary concern, improving the health of their employee population. So what happened, and it was a very interesting process, is that once the Affordable Care Act was released and people had a chance to digest the information, some of the organizations that were concerned from the consumer or the employee advocacy perspective had voiced their concerns to the government, and then others that were interested in this not only from the employee perspective but from the employer perspective had also voiced their concerns, and I think you may be familiar with some of those public documents that came out over a year ago. Well, I was actually in Senator Harkin's office a year ago this month and was talking with his healthcare staff, and they mentioned to me that this had become one of the largest discussion points, and one that was so controversial was the appropriate use of outcomes-based incentive approach in a wellness program, and asked us, HERO, what our position might be on this. And so we formed a group of our members of our think tank to really study the whole issue of incentives, and specifically outcomes-based incentives. And then in February, as I mentioned, we got together with American Heart, Cancer, Diabetes, and the American College of Occupational Environmental Medicine, ACOM. So that group met in Atlanta on February 1st. There were about 35 of us either on the phone or in the room, and it represented all those different groups. It represented employers who actually have these programs in place or are thinking of going in that direction. It represented benefits consultants who are working with clients who have those programs or are thinking of going in that direction. It represented providers in the same fashion. It represented the corporate medical directors through ACOM's voice, and then it represented the employees and the consumer advocacy group through the other groups. So it was a broad-based discussion, and about 35 people, and we spent a full day just talking about what our concerns were, what our approaches were, and was there an opportunity for us to find common ground in this discussion. And if we did, what would that look like? And we came away from that meeting believing that we absolutely could find common ground. And I think the employers that participated in that discussion really helped some of the groups who were concerned about the employers' approach to this whole area of outcomes-based incentives. What their intent was. It came across loud and clear from the employers that it was really about improving the health and trying to improve the health of their employees, and that they were not at all trying to discriminate between different groups of employees. And so I think as we started to get through that discussion and started to talk with what our concerns were and how what kind of evidence is out there based on just experience that some of the providers' clients had implementing these programs, we were beginning to form a collective opinion. And what we came away with was we agreed that we did not necessarily, we don't have enough information to be able to say whether we would recommend or not recommend this approach. That wasn't really our position. But what we really felt was necessary was to be able to give some guidance to the employers, first of all, who are either thinking of or have moved in this direction, around some of the elements that they should consider in terms of including outcomes-based incentives in their program. And then secondarily, we thought that one of the results of this guidance could be to help guide the regulations that are being created by Department of Labor around this legislation, which are still forthcoming. So as we talked about it, we said that there's really two key elements in the legislation that needed to be addressed because they were not well defined. The first is what constitutes a reasonably designed program, and then what's a reasonable alternative standard for those that, because of medical conditions, cannot achieve the health standard that is being requested. And then the third piece that we said we should identify was what are some of the future research questions that need to be answered so we can improve our understanding of the use of these types of incentives and really of all incentives. So, as you know, we created this joint consensus statement, and this was published online and has also been published in print version by the Journal of Occupational Environmental Medicine. You're welcome to download it by either going to the Journal of Occupational Environmental Medicine's site, or you can go to HERO's website, www.heroa.org, www.hero.org, and the paper is posted on our website along with some associated materials, and you're welcome to take a look at that. And if you think, as you review this material, all of our groups are asking that as you review this material, if you either individually or your organization that you represent feel that this guidance is appropriate, we encourage you to endorse the guidance, as you'll see some organizations have done and who are listed already as we start this process, because we think this is really important to be able to speak with a voice on this important topic. So what's the guidance? Well, first of all, we believe that the fundamental goal of any wellness program should be providing opportunities for individuals to improve their health and wellness, and that the program really shouldn't threaten an employee's ability to maintain their health insurance. So we agreed upon that, and this would conflict with improving the whole goal of improving their health. So we agreed that the goal would not be to deny insurance coverage to anybody or make it so expensive that they would not be able to afford it. Also, we suggested, the evidence suggests that long-term lifestyle modification or risk factor management requires more than financial motivation. And of course, we're still early in all of that, but there's going to be a lot of research that needs to be done yet. We know that a certain amount of financial incentives do, in fact, increase participation in programs, but it's yet to be determined whether they really have an impact in terms of person really modifying their health behavior. And we know that success in modifying these health behaviors is based on both intrinsic and extrinsic motivation, obviously with the financial incentives being the extrinsic and extrinsic motivator. And third, we know that one of the keys to these, to a successful worksite wellness program is being able to maintain this or sustaining this change in a worksite culture, environment that supports health and wellness. And this gets back to our vision of creating a culture of health throughout the United States, and some of the work that we've done at HERO with our HERO scorecard, which really asks questions around strategy and leadership development, and really gets at the question of, is your organization, if you have a program, is your leadership committed to creating this culture of health, or including health, integrating health into the culture of the organization so that the employees truly have a feeling that this is an important part of what the organization stands for. Then we wanted to look at what a reasonably designed program might look at, and so we used the HERO scorecard in its 6 domains of questions that we asked as our model, because we felt that through the development of the scorecard by many of the top researchers in the field who went through an extensive literature review, and it came up with the questions and as well as the scoring system, and that we've had the program out there for a period of time, and it's shown to be quite valid in terms of relating outcomes to process in these programs, that this was a good construct for us to promote a reasonably designed program. And the program elements that are incorporated in the scorecard and that we believe are reasonable for a program include a long-term strategic plan, a multi-year strategic plan, if you would, cultural support, as we mentioned, from the leadership, both through their support of the program and their active support by being engaged themselves, hopefully. And that programs for assessment and screening are an important part of this, that a program is just not, our concern was a program in some employer situations would not just be this outcome-based incentive, but that it would have behavior change interventions, programs and activities and information that's available to the employees to make sure that it helps support them as they work along this road of improving their personal health. Engagement is an important part of that with communications strategies. It's important that communications be part of it, and that incentives, if they be used, that they be appropriate and in a value that reflects what's trying to be accomplished by the organization. And that finally, that some form of measurement and evaluation be included in this program. So these are the basic elements. And in our paper, if you go to it, you'll be able to see where we describe those in more detail. Then we looked at specifically at incentives, of course, and said, what do we think about in terms of giving guidance around incentive design? And we really felt that, first of all, and this is a part of the legislation, says that it has to be related to health promotion and disease prevention. So the goal of the incentive has to be to promote health promotion and disease prevention programs that will have a positive impact in reducing the degree of chronic disease. The legislation also talks about them not being overly burdensome and so hard to achieve that it would either from a time or a cost perspective be overly burdensome on the individual. And importantly, as we said, that it cannot be a subterfuge for discrimination. And this is an important part, and we discussed that in great detail. And then what we thought was, well, what should our guidance be around what kinds of metrics to be used? And here we used the experience of some of the providers who are members of HERO and others, and then we used the guidance from some of the federal guidance that's been provided, and came up and agreed that that 4 factors make a lot of sense in terms of designing this outcomes-based incentive program. One being tobacco use, the second being weight through BMI measurement, the third being blood pressure, and the fourth being cholesterol. And also, obviously, that only health status factors that are modifiable for individuals through change should be considered. Employers, we felt, really should factor in how much time and what the financial barrier is for the employees in terms of achieving these health standards. And we want to make sure that the incentive design doesn't place a greater economic burden on one race or ethnic group than another. And then finally, when the incentive is created, that the employer think about whether this should be a reward or it should be offered as a penalty. Both, it could be in either, and it really relates to what the culture of the organization is really all about. And so there is research that shows that takeaways do have an effect. So that's one piece of it. On the other hand, seeing this as a reward can be very beneficial as well. Other important considerations that should be noted is, did the amount of the incentive really fit within your culture? Although 20% going to 30% of the total health care premium, we saw the dollars involved there, allows you great latitude in terms of offering large incentives. Does that really fit within the culture and what you're trying? And secondly, would that really drive the amount of behavior change in the population that you're asking for? And then third, if you use penalties, will they have a disproportionate impact against different income levels or racial or ethnic groups? What's the impact of these incentives? And then a further concern or consideration is if the incentives are so large and cost-shifting to non-participating or non-attaining employees, does it jeopardize their affordability for their health care coverage? So there's a number of things that have to be considered in this as you design and determine what the amount of the incentive might be. And then extremely important is that the design would eliminate a participant's access to group coverage, which would really run counter to the fundamental goal of a reasonably designed program to promote health, which is the baseline for allowing this discrimination in terms of providing reduced health insurance premiums to those that attain health standards. For those who have medical conditions, then the question became, what should reasonable alternative standards look like, because the legislation requires that that be offered. And we suggest that a standard needs to be offered, alternative standard needs to be offered to employees where it's unreasonably difficult to achieve a health standard due to the medical condition or who have a medical reason that makes it inadvisable to do so within the allotted time. And this is in the legislation. And also for employees with medical condition barriers to meeting the health standard, we feel that the employer should defer to the view of the individual healthcare provider for setting and achieving these standards or providing a waiver. So when you are designing your incentive program, we recommend that you consider designs that use goals that are more flexible than reaching ideal targets. So is it reasonable for someone who has a 40 BMI to have to achieve a 25 BMI in order for them to be able to earn the incentive? Can it be achieved? What are the health risks involved in that? And that's one of the things that you need to consider as you're designing your plan. And we suggest that you be flexible when it comes to the use of alternative standards and use them to help individuals with higher health risk and improve their health habits and overall health as well. So thinking about this whole goal of improving health is now a reason to be offering incentives. What is a reasonable, let's use BMI as an example, what's a reasonable amount of BMI reduction for those that have health risks? They may be diabetic, they're obese, they may be diabetic. What kind of improvement is a reasonable? Is it 1 BMI over 12 months? Is it 2 BMI? Those are things that need to be considered, to be flexible, to give people the incentive to really try to improve health, and not to look at these standards as unattainable, ones that they cannot be able to achieve, and therefore ones that they don't participate in improving their health around. One other thought that we have also is we believe that rather than offering just one health standard tied to the incentive, for example, stop smoking, we believe that, and this is through, again, the experience of some of the providers and our discussion, that it would be much more equitable and would have greater impact to have multiple targets in the plan and to be able to spread the amount of the incentive over these multiple targets that are being offered. And that allows people that need to reach their targets through alternatives more opportunity to be able to achieve improved health. We talked about, I just talked about this, about a reward or penalty that's so large that it discourages employees. What's interesting also is, again, through these discussions that we've had as we were putting together the guidance document, that some of the provider members involved in this had some experience because, again, going back to the original HIPAA statute that allowed 20% reduction or increase in insurance premium related to achieving health standards. It's been on the books since I think it was 2006, 2007. That some of these providers have been working with clients along that line. They have some experience in terms of what the amount might be that would actually move the needle for employer populations. And the suggestion is that amounts that range somewhere between $40 and $60 a month, based on very limited evidence and not peer-reviewed research, but just experiential, that somewhere between $40 to $60 a month can be in the program, would be capable of generating behavior change by many of the participants, at least in the short run, because again, we haven't got a long enough time frame to be able to see whether or not it will have any long-term effect. But at least in the short term, that it seems like it takes $40 to $60 a month among those organizations that we have some experience in tracking for them to be able to get behavior change by many of the participants. So that's something to consider. Um, as we mentioned, as you design your incentive plan, one of the things that we really strongly believe in is that the plan looks at providing rewards for progress towards targets instead of just rewarding employees who meet the goals. So again, in order to start to move the population in this direction, think about how you might use what has been described by some as progress-based incentive approach, moving from participation-based towards outcomes-based if that's your plan, and as a progress, providing incentives for people who are able to make improvement in those health standards that or health targets that we're trying to attain for them. Another thing is think about the idea of how can you individualize these programs so that it fits better within their framework, so that they're able to make these changes over time, and think about creating tailored, individualized programs. This may be in conjunction with consultation with health coaches, with the employees, or other ways, but how can we individualize this so it really is attainable by the employee? And I think that's a very important point as well. So to learn more, to read more about this, you can see, you can go to the Journal of Occupational Medicine. You can go to our website or the website for any of these collaborating organizations, and we welcome you to give us your feedback. We're really looking for feedback, questions, and suggestions relative to this whole area of the appropriate use of outcomes-based incentives. So with that, I think we're completed with the part that I wanted to share, and we just open it up, Michaela, for any questions.
Super. Well, please type in those questions now, and we will get through as many of them as we can. You know, as you were talking, I was one of the questions from Craig. I was wondering if somebody would ask that question, and Craig is wondering. He said you were just saying how to use incentives, and it seems that we should be asking maybe if to use incentives at all.
Right.
Maybe the first question is, are incentives beneficial? Does research show that?
You know, it's interesting. Last week, actually, I was in Detroit and had a chance to visit with Dee Eddington, you know, who's certainly one of the great experts in the field, and we talked about this very specifically, and his feeling is that incentives should not be in these programs. And then the next day, I had a chance to visit with Kathy Bossi from Dow Chemical, who many of you know, and their program has been very successful over many years, and they don't have incentives in their program. So we did not address whether, and Craig, thank you for the question, it's an important question. We did not feel that within the scope of this particular document that it was appropriate to address whether or not incentives should be in a program. That should be left to other times, to other documents, and there's still a lot of work to be done. But we thought that because so much of the market is moving in this direction, that we needed to provide some guidance for employers for their consideration as they move in this direction. But it's a great question. There's many organizations that don't offer these kinds of incentives at all. And really, what we believe at HERO is it really comes back to the culture that you've created. And what kind of a culture do you have? We know that incentives will increase participation, but what is the culture like? And if the culture is appropriate, it may be that incentives are not necessary at all, such as at Dow, where they have a very strong leadership that really is committed to the importance of employee health as a very important part of their business strategy. Thanks for that question.
Super. Okay, here's a question from Kathy. She's wondering what mechanism beyond self-reporting can be used to verify non-tobacco use?
Well, of course, you know, I think through screening, you know, I was going to mention this too, thanks Kathy, you know, one of the things that especially for those organizations that are moving in the direction of outcomes-based incentive. An important part of that, of course, is screening events. And we are actually, this group of organizations is working collaboratively to create a guidance document for employers around screening, specifically around screenings events. So that's all part of it, and we feel like this document around screenings event will help employers as well consider whether to offer these on-site screenings and how they should be done, and we hope to be able to give a fair amount of guidance in that area.
Yeah, I think that's really needed.
Yeah, and that'll be coming out later this year. In fact, we had a meeting of that group. That's about 25 people representing these organizations. They're working very diligently on creating this follow-up document specific to screenings.
Super. Yeah, I think a lot of people have questions around that, and it kind of dovetails pretty well into Patty's question. With this, how does this relate to incentive guidelines within HIPAA? Talk about that some more.
Yeah, well, it directly relates to those incentive guidelines within HIPAA, and of course, our guidance is that this is not intended to be a legal determination. You still have to work with your own attorneys to look at the design of your program and how it complies with HIPAA. But what we did was actually look at those at the legislation, the Affordable Care Act legislation, which codified the HIPAA regs or statutes around this area. So it very specifically addresses the issue around the HIPAA requirements as they relate to these differentials in offering reductions or increases in insurance premiums for people who either achieve or don't achieve these health standards.
Well, keep asking your questions. It's living near Washington, D.C., I had I wouldn't exactly say pleasure, but maybe the opportunity to have direct insight into how, as this was being formed, I was, sitting at this massive table at the U.S. Chamber where, for example, the American Cancer Society were very, very adamant about protecting people with cancer, and how to ensure that these guidelines don't discriminate against, people with disease states.
Right, exactly. So those people were at the table as we started to put this guidance together. And, what HIPAA really says, there are 5 requirements, and I'm just going to cite those requirements. One is that the total amount of the reward or penalty is contingent on satisfying a health standard, must not exceed 20%, as we said, and goes to 30%. 2, that the program must be reasonably designed to promote health and wellness, which we discussed. And again, the whole concept of what's a reasonably designed program is really one we tried to address in this document. The third one is that individuals should be offered the opportunity to qualify for the reward under this kind of a program at least once a year. And then fourth, that the reward should be available to all similar situated individuals. If it's unreasonably difficult due to an employee's medical condition or medically inadvisable, the individual should be offered an alternative. So this becomes the alternative standard piece. And then fifth, communications is important, and it suggests that all program communications must describe the terms of the incentive and must clearly disclose the availability of a reasonable alternative standards and the possibility of a waiver. So those are the 5 basic HIPAA requirements that are addressed in the legislation.
And there certainly is.
And as you notice in our conversation, we're addressing alternative standards and a reasonably designed program, which are the 2 elements that are really not described and left very general. And based on the consensus of these groups looking at it from very different perspectives, what we agree on should be the approach.
Well, I think it's a monumental task that you've.
Well, one of the interesting things about this is that we were actually, as a group, be able to come together from very different perspectives and be able to speak with one voice. And I think that, Michael O'Donnell, early on in this discussion, talking, about this whole approach in talking about the importance of speaking with one voice and some of the things that he's written, that we were actually able to do this. And I give great credit to the consumer advocacy groups for really reaching out, because they reached out to us to see if we would be willing to sit down, convene a group of employers, consultants, and providers to discuss this whole approach together, to better understand the approach, how it's being used, and to discuss some of the concerns that they had. And it was through that collaborative process that we got to this point. And I think it speaks well for the future of the field and how we can come together even though we have different perspectives in many things.
Absolutely. Kathy, was wondering if you could reiterate. I think you said that that the incentive differential goes to 30% in 2014.
Yeah. Yeah, according to law, it goes to, it can go up to 30%. Doesn't mean you have to offer 30%, obviously, but it means that you have leeway to go up to 30% in 2014, and gives HHS the ability to raise it to 50% if they believe that it's being very effective, and raising it to that level would be important.
Well, it's certainly an interesting idea. I think about, when on the one hand it's carrot and sticks for sure, but think about how long it took to change, the general population thoughts on tobacco use. And, is this the beginning of that? I don't know.
Well, we address that a little bit, because we talk about, when you think about seatbelt use and worksite safety and recycling and smoking, in those areas, there's a lot of the times there was financial incentives that were used in either fines or user fees or other kinds of financial incentives that were designed. But along with that, if you think about these other areas where we really kind of made societal changes in the way we did things, there was a broader strategy that was part of that dealt with capacity building, educating the population, creating a culture where these new norms were acceptable and were actually preferred, and policy then followed that. And and I think that, again, when we look at this whole issue of incentives, it's within the structure of a well-designed program. It should be considered as a tool that may be used, and not as a program itself, but really as a tool. And we feel, as I mentioned at the start, that the base of that program is really around building a strong culture of health, or building health into the culture of the organization.